Hey guys, it's Medicosis Perfectionalis once again, where medicine just makes perfect sense. In previous videos, we talked about urine electrophoresis and urine Bence-Jones proteins. We talked about microalbuminuria and microglobulinuria, i.e. the beta-2 microglobulin. We talked about urine potassium, urine uric acid, urine chloride, urine ketone bodies, urine catecholamines, urine bilirubin, and urine urobilinogen. And we talked about protein in the urine before, but today let's talk about the types of proteinuria because it can make a big difference. So let's get started. Please watch the videos in this playlist in order, especially my video on urine proteins. A good kidney should not let any protein or blood into the urine. A kidney with nephrotic syndrome lets in tons of protein in the urine. A kidney with nephritic syndrome lets in mainly blood in the urine. The kidney is inflamed, itis means inflammation, and shedding tears of blood. Normally, the plasma proteins should not end up in your urine. Why not? Who's preventing them? Two forces. Number one, the fenestrations of your endothelium are very narrow and the proteins are big, so proteins will not fit. Number two, your glomerular basement membrane is negatively charged and the proteins are negatively charged. If you remember my video on urine electrophoresis, they were negatively charged. That's why they were attracted to the positive electrode. So negative here and negative here, they will repel each other. That's why normally you will not see proteins in the urine. But what if I lost the negative charges, like minimal change disease? Oh, I can see some proteins in the urine. What if this barrier got destroyed? Well, then the kidney is wide open. Recall that your blood contains plasma. The plasma contains water and plasma proteins. The proteins are albumins and globulins. Albumins are smaller, more numerous. Globulins are bigger, less numerous. Therefore, let's say that I have diabetes. Which one will be lost first? Of course, the smaller one. Albumin will be lost before the globulin. That's why we measure albumin in microalbuminuria test, which can help us diagnose diabetic nephropathy early on, way before the overt proteinuria takes place. What's wrong with losing proteins in the urine? If you lose proteins in the urine, especially albumin, you'll get edema. If you lose globulins, you will lose your gamma globulins, leading to infections. And I keep losing proteins, so I end up with edema, I end up with thromboses, infections, and hyperlipidemia. Nephrotic syndrome makes me lose tons of protein in the urine, and we talked about nephrotic syndrome in great detail in my nephrology playlist. Nephritic syndrome can also help me lose some protein in the urine, although not as much as nephrotic syndrome. Not all proteinurias are created equal. We call them 1+, 2+, 3+, 4+. 4+ is the nephrotic range proteinuria, very severe. Just 1+ is called microalbuminuria. Then it becomes macroalbuminuria. Worse is the symptomatic proteinuria. Then yet nephrotic range proteinuria. Proteins in the urine can lead to the formation of casts. What are casts? They are blocks, like ice cubes. If your ice is shaped like a cube, I can guess the shape of the container that contained the ice. It was shaped like cubes. Similarly, if I see these shapes under the microscope while examining the urine, I know that they look like what? Your tubules. So I know that whatever disaster that is, it's coming from your kidney's tubule. I will not blame the bladder or the urethra or anything else. Your problem is in the kidney's tubule. Proteins in the urine can lead to the formation of hyaline casts mainly. That's why we call them proteinaceous casts. What's the name of that protein? The TAM Horsfall protein, which was discussed before in this labs playlist. We talked about urine protein before. Here is the normal on the spot urine test and on the 24-hour urine collection. And these are the causes of proteinuria. Don't forget diabetes, amyloidosis, lupus, multiple myeloma, heavy metal poisoning, myoglobinuria, and hemoglobinuria. And don't forget the drugs, namely antibiotics. And now to the crust of the issue, the types of proteinuria. Proteinuria could be functional, i.e. not a disease, It could be due to overflow, just like my cup is overflowing. The kidney is overwhelmed, too much protein is coming in, and the kidney does not have the capacity to reabsorb all of this protein back to the blood, so the protein ends up being lost in the urine. Or it could be a problem in my glomerulus or a problem in my tubules. So let's go. Functional. Could be orthostatic or otherwise. What do you mean by orthostatic? Ortho means straight. When I'm standing up, I get proteinuria. But when I'm not standing up, there is no proteinuria. So who suffers from that? Police officers, security guards, chefs, teachers who actually teach, farmers who actually farm, ushers, or any person who stands up for a living. And don't forget your surgeon. They will have proteinuria when they are standing up for a long time. So it's mostly in the evening because they have been standing up throughout the most of the day. But when they lay down to rest at night and they wake up in the morning fresh, there is no proteinuria in the morning. This is characteristic of orthostatic proteinuria. This is not a disease. But hey, medicosis, what if the security guard has the shift at night and he sleeps in the morning? Then it's gonna be the other way around. I mean, use your brain, dadgummit. Non-orthostatic causes include strenuous exercise, stressful situations, cold baths, fever, congestive heart failure. All of these can lead to functional proteinuria. Do not blame it on the kidney, please. The kidney is fine. There is something else causing the protein to be lost in the urine, and usually this proteinuria is less than 2 grams, unlike the nephrotic syndrome, which is greater than 3.5 grams per day. Next, my cup overfloweth. More is coming in than I'm able to reabsorb back, such as myoglobinuria, tons of myoglobin, which is a protein, coming into the urine. Maybe because I have a crush injury, or a severe car accident, or a trauma, or March proteinuria for military recruits, or it could be hemoglobinuria, mainly after intravascular hemolysis, not extravascular for the most part, because in extravascular, all of the gunk is going to go to the spleen and the spleen will clean you up. However, intravascular, all of the gunk is going to go to the blood, not to the spleen. And when it goes to the blood vessel, it's going to end up in the kidney. It's going to show up in the urine. Next, multiple myeloma, where you see Benz-Jones proteins. What are they? They are the light chains of the antibodies, of the immunoglobulins, which are gamma globulins. Recall that globulins are plasma proteins. Next, glomerular diseases. It could be nephritic or, the worst, nephrotic syndrome. In nephritic syndrome, like glomerulonephritis, the protein in the urine is less than 3.5 grams in a 24-hour period. But in nephrotic syndrome, I'm losing too much protein in the urine. It's more than 3.5 grams per day. And when you lose all kind of proteins in the urine, you can get edema, of course. And don't forget, kidney disease has also periorbital puffiness. And we talked about that before in my video on acute post-streptococcal glomerulonephritis. Last, tubular disease can lead to proteinuria, big time. Who's destroying my tubules? It could be a destruction or a damage to your proximal convoluted tubule known as Fanconi syndrome. I've talked about it before. Do not confuse Fanconi syndrome with Fanconi anemia, please. Or it could be that I have an autosomal recessive disease where my kidney tubules cannot reabsorb neutral amino acids like tryptophan because the transporter is toast. What's going to happen? If you cannot reabsorb these amino acids, they will end up in the urine. That's a proteinuria. Technically, you can call it amino aciduria, but amino acids are related to protein, so who cares? How do you treat these patients? Give them a high protein diet because they are losing proteins in the urine. Give the patient what he lost. It's a basic rule of medicine. Patient is dehydrated, i.e. lost water, give the patient water. But if the patient is volume depleted, i.e. lost salt and water, then you should give the patient salt and water. It's called normal saline solution. If your patient had third-degree burn and lost tons of albumin by oozing through the burnt skin, then give the patient albumin, but not in the first day. Wait until the second day, because if you give it in the first day, it will ooze through the burnt skin, and it's pointless. So in the first day, you give the normal saline. Then in the second day, you can introduce the albumin. That's how you become a good doctor, not another doofus with a stethoscope. Third, heavy metal poisoning. Oh boy, heavy metals are very good at destroying your kidney tubules. antibiotics can cause that as well. So let's summarize. Proteinuria could be functional, overflow, glomerular, or tubular in nature. I'm standing up or under lots of stress. What's coming in is too much to bear. The endothelium and the basement membrane are wide open. And my tubules, especially the proximal tubule, cannot reabsorb the proteins back. Hi medicosis, can you tell the difference between a glomerular cause of proteinuria versus a tubular one? Of course, haven't we talked before about microalbumin and beta-2 microglobulin? You can use them to tell the difference between glomerular disease and tubular disease. If you want to learn more about the function of the proximal convoluted tubule, the loop of Henle, the distal tubule, the collecting ducts, the countercurrent multiplier, countercurrent exchanger, titratable acidity, the story of ammonia and ammonium chloride, download my kidney physiology course at medicosisperfectionalis.com. If you want to learn about pharmacology of the kidney, i.e. diuretics, download my cardiac pharmacology course. If you do not prefer to download and would rather watch all my premium courses right here on YouTube, then click on the join button next to subscribe below this video. Sometimes it does not work on your phone, sometimes you have to go to a computer, and then choose the highest tier that contains all of my courses. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my notes, courses, and cases. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.